This toxicology curriculum is brought to you in collaboration with McMaster University, Western University, and the University of British Columbia. This part of the Toxidromes section focuses on opioids and other sedative hypnotic agents. By the end of the session, you should be able to recognize the opioid and sedative hypnotic toxidromes. You should also be able to formulate an approach to managing this type of toxicity. Let's start with a case. This is a 19-year-old man who was found collapsed at a party. His GCS was 9, heart rate 52 beats per minute, blood pressure 110/64, respiratory rate 8, and a temperature of 36.7 degrees Celsius. His oxygen saturation was 93% on room air, and his pupils were 3 millimeters. What toxidrome is this? And think about the types of exposures that could produce this type of presentation. If you saw that this case has features of an opioid toxidrome or even a sedative hypnotic toxidrome, you would be correct. But before we talk more about these toxidromes, let's clarify some of the terminology. Opiates are substances that are derived directly from opium poppy plants, such as morphine or codeine. Opioids are substances that are capable of binding to the opioid receptor. This can include opiates, as well as semi-synthetic substances that are chemical modification of opiates, such as heroin or oxycodone, and synthetic substances that have no structural similarity to opiates, like meperidine or fentanyl. Narcotic substances, on the other hand, are sleep-inducing agents and include opioids as well as other sedative and hypnotic agents. Because of the similar features of an opioid and sedative hypnotic toxidrome, they are sometimes combined together into a narcotic toxidrome. Narcotic agents include opioids, barbiturates, benzodiazepines, zobaclone, chlorohydrate, ethanol, and GHB, or gamma-hydroxybutyric acid. The classic opioid toxidrome consists of 3 main features: CNS depression, respiratory depression, and meiosis. It's the respiratory depression that's the most important defining feature of opioid toxicity, and this diagnosis should be considered in any patient with a respiratory rate less than 12 breaths per minute who's not sleeping. Other features of opioid toxicity can include acute lung injury or pulmonary edema, dysrhythmias, and hypotension. There's a condition called rigid chest syndrome that's been described most frequently in the context of high-dose fentanyl exposures. Seizures can also be seen, for example, following meperidine exposures for prolonged periods of time or in patients with renal failure due to the accumulation of the metabolite. Compartment syndrome and rhabdomyolysis may be a complication of patients that have been found down or immobile for prolonged periods of time. The sedative hypnotic toxidrome has many similar features to the opioid toxidrome. CNS depression is typical, however agitation or ataxia may be more prominent in some patients. Pupils are usually normal or dilated in size, although meiosis can also be seen. And hypoventilation can be present, although it's typically not as pronounced as with opioid exposures. Other features can include hyporeflexia, bradycardia, and hypotension. It's important to remember that there are many reasons for decreased level of consciousness or coma. Any patient presenting with CNS depression should be treated similarly, initially with resuscitative measures and the ABCs, and then followed by the coma cocktail, which can be both diagnostic and therapeutic. This consists of dextrose, oxygen, naloxone, and thiamine. If opioid toxicity is present, one would expect a rapid response to the appropriate dose of naloxone. There is some theoretical risk of naloxone-induced opioid withdrawal in patients with opioid dependence. However, the features and symptoms of opioid withdrawal, such as yawning, lacrimation, diaphoresis, vomiting, and diarrhea, may be unpleasant, but they are not life-threatening, and this should not prevent the administration of naloxone to a patient with apnea or respiratory depression. Naloxone is a competitive mu-opioid receptor antagonist and reverses all signs of opioid intoxication. It has several routes of administration, including IV, intranasal, endotracheal, subcutaneous, and intramuscular. Oral administration is hampered by low bioavailability due to high first-pass metabolism. It has a rapid onset of action within 2 minutes and a half-life between 60 to 90 minutes, although the actual duration of action ranges between 20 to 90 minutes, which is significantly shorter than most opioids. For this reason, repeat doses of naloxone may be necessary or even the initiation of an infusion. It's also important to recognize that patients need to be closely monitored for the return of respiratory depression following the discontinuation of naloxone. Here are some follow-up questions. Name 3 scenarios where opioid toxicity will not present with meiosis. Describe the opioid and sedative hypnotic withdrawal toxidromes. What are the main differentiating features between them? And describe the use of antidotes for the sedative hypnotic toxidrome.